Hello, everyone. We're sitting at the Place de Congrès in Paris at the Quality and Safety Forum. And I am a paediatrician, Peter Lachman from London. I work at Great Ormond Street. And we're going to have a session today on paediatric patient safety. Some of my colleagues from the Paediatric International Patient Safety Collaborative community are here with me, and they're going to help discuss the issues that face children in navigating through healthcare. I first have Annie Molden, who's from Melbourne. She used to be at the Royal Melbourne Children's Hospital and now at Southern Healthcare. I have John Fitzsimons, who is in Dublin at Drogheda, and Johnny Tates, who's at the Westmead Children's Hospital in Sydney. We all work in this international collaborative, and we're all paediatricians. But we're going to cover a wide range of issues that face children in healthcare. The first question we need to ask is, why are we here in the first place? Why are children different? Are they different, and do we need something else? So I'll open that to the panel. Annie.
So one of the things that are important, I think, in terms of looking at children and adults in patient safety is what are the specific risks that children have in hospitals, and then what are the risks that they have much more broadly in terms of healthcare. And so Johnny might want to talk first about the large children's hospital setting.
Well, in a large children's hospital, the positive is that most of the staff, nursing, medical, adult health, are specifically trained and in tune with paediatrics and with children's health, which is quite different to a district hospital. However, the nature of the work that we do is that the kids that are coming into the tertiary and the quaternary hospitals are incredibly complex, often with multi-system problems, multiple hospital admissions, often requiring ICU. And as we know, each and every one of those admissions brings with them a risk of harm, a risk of complications from medication, from fluids. And so I think the challenge for tertiary and quaternary pediatrics is around dealing with kids with multi-system complex problems in a system that is really poorly designed to meet those needs.
In Ireland, in the DGH?
In the DGH setting, I think there's big differences from the children's hospital. I mean, most pediatrics, I think internationally, is provided probably in DGH settings around the world, where there is a team of paediatricians and paediatric staff who look after children, but there's also many other providers who will look after children as well, especially when they're particularly unwell. So professionals such as anaesthetists, radiologists may be called upon when children are very unwell. And I think those individuals often have some paediatric training, but it's quite limited, and I think they don't have the same, I suppose, understanding of issues like drug doses and the fact that everything we do is calculated on per kilo basis, and so there are major issues, I think, around staff in particular, I think, at the district general hospitals.
If I could add, one of the major problems is that children don't come in one size. They start as babies, they go up to teenagers. And there are risks. In fact, the biggest risks are if you at each end of the scale. So the biggest risks are the neonates, and then there's the adolescents, because the paediatricians have stopped understanding what to do with adolescents. And I know at Great Ormond Street, those are the two highest risk patients in the quaternary hospital, the very young and what we would call the very old, who happen to be 16 or 17. And of course, the 16 and 17-year-olds, then they go to the adult care. They get very poor business from adult care wherever they go, because they still don't understand that end of the scale. So the risk is pretty high just because of basic physiology of children.
I think that's actually really important. I think particularly if you look at how successful rapid response teams have been around the world, and they have been, but there's a real challenge in terms of in paediatrics, because you can't just have one set of criteria. And most hospitals have different age groupings, but there isn't a sort of an agreement on clear criteria for how you quickly navigate a deteriorating patient.
I just wanted to pick up on one of Peter's points. That would be very much the Sydney experience as well. So when we looked at our data around adverse events, the standouts are the neonates and the under 3-month group, and the 16 and 17-year-olds. And I suspect that would be the international experience around children's care in tertiary centres, because there's such a challenging subgroup within paediatrics. Perhaps in the future we ought to pay more attention to specifically those two groups.
If we add quality to the issue of what happens to children, is that when I trained originally, I'm old enough to remember that if you came with leukemia, you had a 95% chance of death. Now it's exactly reversed. You have a 95% chance of survival. And we could list a whole host of conditions where children who used to die now live. And most of my business is with children who have lived who normally used to die, the children who are survivors of neonatal intensive care and have chronic conditions, and they are exposed to a whole host of harm that they would not have had otherwise. So it's a continually changing ballgame because of what we've done in our success in getting people or children to survive.
And my practice would be very similar to yours. In other words, I would often coordinate a team of 10 or 11 subspecialists around kids with complex care. And I think one of the positives, because we've talked about some of the negatives, one of the positives of pediatrics as opposed to our adult colleagues is that we do still have generalists. And I think we underestimate the role of general pediatrics within the greater pediatric world.
That was quite interesting because in Nigel Edwards' talk today, he said we must bring back the generalists. We have generalists in pediatrics, but the big problem in pediatrics is that these children with very complex needs have to traverse so many different subspecialists, living in their silos, looking at one part of them, and not understanding the complexity of the illness, and that's where the generalist is very important.
So where the adults come into trouble, I think, is that you often have, let's say, an 80-year-old woman with a list of 10 chronic conditions and gets assigned to one organ doctor. So she may have come in with a stroke and the neurologist is assigned to the lady, but she's also got diabetes, high cholesterol, hypertension, gout, peripheral vascular disease, and I think that's why adult care has become so complex. So one of the things I think we should really cherish in the future is to maintain that role of the generalist pediatrician.
So let me just say, we think that children are different.
We know they are.
Yeah, we know they are. But we know that within the children's spectrum, the baby is very different from the adolescent, and there are different problems we need to solve. So it's not something that we can do ideally just by having one approach. Am I correct? Do you think that's John?
Yeah, absolutely. I mean, if you look at one of the key problems we have in our centre, and again I think it's an international problem, is recognising deteriorating children. Now, there's been a lot of work done on developing early warning scores for adults. But when we look at children, we've got to take into account that the physiological parameters for a small child are different than that for a middle-aged child and for an adolescent. Yeah. So we've had to design different early warning scores for all our different age groups, and that takes into account that difference.
And then we have to consider the fact that as you said earlier, most paediatric care is not delivered in a high-level children's hospital, and in fact it shouldn't be. And so most paediatric care happens either at primary care level with general practitioners in the community, or in small district community health centres or small hospitals. And there you have people who may be paediatricians, but much of the medical care is provided by people who've got limited paediatric training. And so what we need to do is be very clear that we've got a set of tools and technologies that can support people who've got minimal paediatric training in making sure that they can pick up the deterioration, or that something can pick it up. So there's an observation chart, for example, that the nursing staff are using that will quickly say when someone has actually fallen into the unsafe range, and can then sort of escalate the concern so that you can actually get people in who actually do have the knowledge.
Yeah. So let me just pick up one point there before we lose it on this lack of paediatric training by the providers of healthcare to children in most places, because I know in the UK only 25 to 30% of general practitioners have had paediatric training. Some areas are higher and some are lower, but it's actually very poor, and they are providing a lot of the care. Now, a lot of the arguments I have is that if you're a good family doctor, you'll be able to manage most of the situation because you can deal with the child within the family. But do you think it puts it at risk unless we have everyone to have some basic paediatric training?
Well, Peter, if you think about it, let's go back to the very beginning, to the undergraduate training. Now, almost all of undergraduate training is adult-based, even within the subspecialities. So it wouldn't be uncommon internationally, in Sydney and Australia, where most interns would have had 6 to 8 weeks of dedicated paediatric training. That's hardly enough to arm them to deal with what are very complicated, complex problems. And I think when I go back to my intern days and my first job in a mixed A&E, I very carefully made sure that I funneled all the paediatric patients and just saw adults, because I was petrified of them. And I suspect many interns have that fear of looking after kids.
So we deal with a structural problem, is that the training is very oriented to the adults because it's provided by adults, yet at least 25 or 30% of the clients are children.
Yep.
And despite the ageing population, that will continue to be. It'll remain a large percent of the work that's done.
So John, you want?
Well, I think it carries through into adult care or into hospital care as well. Past the medical schools, quality initiatives generally start in adult departments. The usual line is that we'll roll that out to paediatrics once we've got it right with our adult departments, but that rarely happens because the initiative changes or it runs out of steam, and so we often get left behind.
So Peter, to complicate things, a lot of the measures that we have to report on are very adult focused and often are very meaningless and not very helpful in a paediatric quality and safety environment.
Could you give me some examples?
So for example, currently one of the measures we have to report on is Clostridium difficile infection, which, as we all know, in kids under 2 or 3 is often just a commensal. It has absolutely no bearing on safety in a children's hospital. It's very much an adult or a geriatric measure.
So that is from the regulators. For example, we have the same problem at Great Ormond Street when we have a ridiculous target of having 9 infections a year, and they're all commensals. They're not real infections, yet it's an adult target. And we can go look at the indicators that they've developed for the country for outcomes. They're all adult focused. So children are generally forgotten. So what I'd like to just summarize what we've said is basically children are different because they're physiologically different. They change over time. And then we have the problem of the adult world not being prepared for children if they're not in a children's hospital. And the vast majority of children are not ever going to go to a children's hospital. They're going to either be in a community or in a district hospital in healthcare. One of the things that really struck me today at the conference is that we've had a number of very good keynote addresses, and they talk about the chronic care plan. And I was quite interested today that they started at the start of disease and at death or resolution. So one of the conditions they showed was chronic obstructive lung disease or chronic heart failure. Surely it should start in childhood. Is that an indication that in the quality and safety movements in conferences like this, pediatrics is still something in the background?
Well, I think absolutely. I
I
think
think we all agree.
there's been very few conversations so far about paediatrics and about children in the context of quality and safety.
It's almost like we're Cinderella speciality, a little boutique.
But why
Part
should we
of-
be different?
I agree. We should be very much front and centre of quality and safety. Just to come back to chronic care, so much of one's life's problems begin in childhood. So if for example, with children, if they learn to eat healthily, exercise regularly, a lot of the problems down the track may be prevented or ameliorated. So I think one of our key challenges going forward is to get the ear of the adult folks and say, hold on guys, we think paediatric quality and safety should be front and centre of this movement because we have a lot to contribute.
It's interesting, isn't it? Because if you actually think about many of the stories that get told, so this morning Maureen was talking about Helen, who's now on the board of IHI, who has a son, Louis, who had an adverse event related to a misdeterioration, which is what they took all their focus initially. And then afterwards there was a reflection about how necessary was that surgery anyway in the conversation that she was having about overuse. And a lot of the stories that have actually driven the patient safety movement over the last decade have actually been harm that has happened to children. And yet it's interesting that we have still quite a lot of a minority of the context and the content rather.
And at most, a lot of the leaders are pediatricians.
Of course.
I think one of the key things as well is this is value for money. If you invest in prevention in childhood, if you invest in paediatric safety strategies, it does pay off. And that's where I think a lot of these pathways do need to start even prenatally and well before the actual manifestation of disease.
So practically, one of the things I'd like to see in the next 2 to 3 years, both at the International Forum and at the IHI Forum in Orlando, is a dedicated paediatric or child and health stream that runs throughout the program, with dedicated speakers and a program to try and get pediatrics more mainstream and to get more mainstream pediatricians to the meeting.
Because I'm going to raise a question about pediatricians. Generally, as I'm a pediatrician, I could say this, we're generally quite nice people and we like children. Yet I find when I'm working in quality improvement and safety, the pediatricians are a little resistant to the concepts that possibly they're unsafe because they like children, and how could they do that to children? Do you find this is a problem, this kind of almost paradox, that they are late to join the party?
I don't think they're any later to join the party than many adult physicians. I think the challenge we have in the quality and safety world, if you like, is actually engaging with medical staff at all levels. I think that we really need to continue to work very, very closely with our colleagues to actually highlight how important it is to actually improve patient safety and reduce harm, and how important it is to improve the quality of the healthcare that they get.
We all know about clinical champions.
Yeah.
And much like we have clinical champions in the adult world, it's just as important to have, paediatric champions around children's health. We've got to find those champions, nurture them, develop them, train them, and release them.
So how could, I was speaking to both John and Annie, who are not working at children's hospitals just right now, how could the children's hospitals who are working and leading on the way in paediatric patient safety translate what they're doing into the world of the paediatrician working within the adult world? Because they've got to really translate it. You can't do it exactly the same.
I mean, I think there's a huge amount we can take from our colleagues in the children's hospitals, and I think things around guidelines for standards of care, because I think safety starts with doing the things right in general, and being confident in what you're doing. And I think to expect each small paediatric unit to develop guidelines when I think that's something that we can do centrally, and with the help of the children's hospitals, that's certainly a big element. I think there are lots and lots of other resources around education, around deteriorating children. One of the things we've started looking at recently is simulation, because a lot of the events that we have to deal with are very, very rare events, and the only way we can really prepare for it is to do that in a simulated environment, which is something we would have to do with our colleagues from intensive care in the children's hospitals. So I think there's a huge amount of
I think
crossover and room for.
I mean, the dissemination of knowledge has to be the greatest thing that the large children's hospitals can give to paediatric healthcare providers everywhere, in terms of guidelines, but also using telemedicine and podcasts and electronic mechanisms of training and education.
I'd actually like to see more of that. I think if I can be critical of my colleagues in children's hospitals, specialty hospitals, they often forget that the bulk of children's care actually takes place beyond our facilities, and sometimes we need to remind them that we have colleagues at the coalface working, with children as well, and that while we can provide a sense of leadership within the children's hospitals, the big children's hospitals internationally, most children's healthcare doesn't take place, and we have to, as part of our responsibility to all children, provide that level of leadership, information, knowledge, and know-how.
So good to pick on your leadership. How do you get leadership it's difficult enough in the children's hospitals to make them focus on patient safety and quality. And now a lot of children's hospitals are doing that in the collaborative, that's what we're doing. But in the community hospitals, how do we get the leadership to place children on their agenda? Because that's a constant battle. When I used to work in a district hospital, that was my main task, was to get the children onto the agenda. And it was very difficult. How do you think most of our viewers will have that problem?
I think one of the key things, and Johnny touched on it earlier, is having indicators and measures where we know that we're doing a good job, and other tools where we can measure harm that are specifically designed for settings, again, outside of tertiary children's hospitals, where we often, it's not clear to us how we're doing, and I think that's really important.
I think we need to be clear about what harm happens in paediatric healthcare, and I think that we know that in the big children's hospitals, a lot of the harm is around medication management, particularly very complex medications, and deteriorating patient. And so a lot of the interventions that have been developed so far have been at that very high end. And I think one of the things that, if you go back to the Don Barron's report in the early 90s. And, you know, harm includes diagnostic delays and treatment delays. And the diagnostic delays is often about lack of knowledge. And the treatment delays may well be around not having the equipment, not having the antibiotics, not having what it is that you needed. So I think we need to go right back and say harm is a late diagnosis, it's a delay in intervention, or it's getting an infection, or it's getting the wrong medication. And there's a whole raft of different things we need to focus on.
One of the challenges going forward will be around measurement. And before recently, the typical response has been, we don't have a way of measuring our performance. We know we're above average. As a hospital, as an individual, as a group. With electronic medical record, with registries, we're now entering the era. I think the next decade internationally is going to be around physician measurement, and that includes pediatrics. And I see no reason going forward why the large children's hospitals couldn't play a key role in developing outcome measures that are applicable both to a specialty children's hospital, but also to the many district hospitals. They'll be different, but it will allow us for the first time to compare our performance.
Children's Hospital America have done that.
Exactly. So Cincinnati are leading the way, and I think that group at Cincinnati will play a very key role.
Yeah.
And for the first time, actually talking about outcomes that measure that are important to children and their parents, who are our clientele.
So one of the tools we developed was quite typical. There was a trigger tool for adults, and John was on the team with me in the United Kingdom that worked on the UK pediatric trigger tool, which is now available to anyone who wants to use it, and is the Canadian version. And I know I've been working with the CHA in the US to do the US version of the trigger tool. They want an electronic one. But I think a good start is for people to start saying, what is the harm that happens in our hospital? And in that, we've defined harm very simply, something you wouldn't like to happen to your own child. And I could just give an example, is that cannulation is a big problem often in children. And now we've defined anything more than 2 attempts as harm. And that's quite a high bar for the average hospital in which they haven't expertise to cannulate. So we are just changing the culture of what our view is, what harm is in children. So I'd recommend to anyone who wants to really start is do the case note review and look at using a trigger tool, whether you use the Canadian one or the US one or the UK one, in order to find out what's going on.
Peter, I think you're quite right in principle. Most of us aren't even aware of the degree of harm that occurs to our patients in a hospital. So how on earth are we going to develop solutions if we aren't even aware of the magnitude of the problem? And I suspect with the trigger tool and other methodologies, we'd be amazed. Because we all think we like children, we like parents, we do the right thing, we're good listeners. I think we'd be amazed. It would be a very important soul-searching exercise to realize the degree of harm that happened to children in hospitals.
And just on the trigger tool, it's not, to me, the actual score is not the most important thing, it's the change of culture.
Yes.
Because suddenly the organization starts considering what does a child have to navigate in order to get best care. And so it's a good start. It's not the only tool. We also developing, was led by the Cincinnati group, they're developing a serious harm index. And we now going to try and work collaboratively with them to work out it's a way we can look at a harm index that covers all harms. And we expect it to go up and up and up until we've got them all in before we can get it to start going down.
Correct.
And I think that's a cultural change that we're going to really do to understand what happens in the hospital or in the healthcare setting. And we haven't even started looking at community child health, the children out there in the community who never get to the hospital because they're experiencing something different.
I think just to come back, it is going to be a culture shock because of the characteristics and the nature of paediatricians and the type of people that are encouraged in that speciality. We have this kind of feel-good solution and that kids are safe in hospitals. Yeah. And I think this work is going to show the opposite, and that's going to lead to a cultural change. And I think that will galvanize the paediatric community to say, hold on guys, this isn't as safe as we thought. We're doing significant and serious harm to children. We need to change, and we need to change quickly.
I think another thing that goes along with knowing and naming the problems is giving our patients a voice, and whether that's directly for children who are old enough to be able to voice their concerns.
So, and that is just to remind one difference that we didn't specify early, is that the children who are very young are very much like the very old, where they haven't got a voice, they have to have someone talk for them. And therefore
and
it makes
on a soft diet, and they're wearing diapers, and they can't talk.
It's a very different story. But I just want to move on to some solutions, because we've defined the problem, we've said we need to look at what harm is, and we need to start studying that in greater detail. We need to develop the measures. We need to know the outcomes, what the quality is. What are some of the interventions that have been around that we've used so far? Besides the trigger tool, we raised the trigger tool to understand harm, but what other things would you say that could, as a take-home message, people could start to using now?
Well, I think, John's already raised the early warning system, met criteria, rapid response criteria. It doesn't matter what the wording is, but having observation charts that are actually colour-coded that make it really, really easy to recognise when deterioration patient is.
I mean, for example, in New South Wales, in the state in which I work, we have 6 age-specific track and trigger colour-coded charts. Every single child, no matter in which facility, from the smallest little country hospital to the children's tertiary and quaternary hospitals, is on the same observation chart. And that sends a very clear message to parents and also to our registrars, nurses. They're all familiar. It's all one chart. And I think that's a huge step forward. Clearly, every hospital will have its own response team because it can't be the same at different facilities, but at least there's a standalone observation chart. And I think that's a very important way of recognising children that deteriorate. Because the one thing I hate, Peter, is when people come to me and say that child had a respiratory arrest unexpectedly. Because we know almost all respiratory arrests in children, they follow a very specific, stepwise, physiological, pathological deterioration. They're not unexpected. And the charts are there to prevent that.
So the first thing is making sure we've got good observations, good record keeping. How about on medicines? How about having a standardized medicine prescription for those who don't have electronic prescribing, which is the vast majority of children in the world? Is there a way we can make prescribing, which is the second biggest one besides deterioration, more safe?
You know, Peter, when you have to tell a parent that their kid may have deafness because one of your resident staff has overprescribed gentamicin by 10 times the dose, this becomes a very real issue. And sadly, it happens from time to time because, as you say, you know, medication is high risk. The numbers are different. It's weight-based. The opportunities for error are great. In Australia, we have a standardised paediatric medication chart for all kids across the country. So that goes some way. But even in our most recent audits, errors are still being made. I think doctors' handwriting is still illegible. There's lots of ways to improve.
I think even knowledge of these errors, we know this 10 times error is a very, very common error because we have to do everything on a weight calculation. I think simply knowledge that is something that happens. You can build in, I think, in terms of, you know, people being aware that the 10 times.
So I'll go back to training on this one, is that in medical school they get 6 weeks of pediatrics and then they get a bit of training on how to write prescriptions and very little is about pediatrics.
Sure, but I think this is a situation that comes back very much to, so I'll give an example of one of the smaller hospitals at the network that I work for, and what they've done, they have a vast majority of their prescriptions are written by orthopaedic registrars, adult orthopaedic registrars, adult plastic surgical registrars, etc. And what they've done is a very, very simple thing in the paediatric ward is they've got a designated prescribing area, and so that it's cocooned in terms of noise. There's a computer, and on the computer, on the desktop, are the paediatric pharmacopoeia, calculator, and all the tools that you actually need to prescribe safely. And I think that in paediatrics we need to really make sure that we give people the tools and that we actually give them the space to actually say, it's complex, we don't want you to remember anything, we want you to sit down and calculate it again and be clear that the risk is actually, the huge risk of paediatric prescribing. You know, we always say in patient safety, don't make people be more vigilant. And so I'm not saying that, but what I'm saying is we have to provide them with an environment, we have to provide them with the tools.
So this really goes on the human factors approach, is that for pediatric patient safety, you have to make sure that you've got the right environment that's child-friendly, and often it's not. A lot of children in the emergency room are in adult emergency room, which I regard that as psychological harm, let alone physical harm. Secondly, you have to have the right tools, whether it be for intubation or for prescribing or whatever. You have to have the right people, and that is trained or supported so they can provide this service. And then you have to have an understanding of the child, the physiology of the child. So that would cover the whole human factors approach. And that's a little different. It's the same as adults, but more specific in a way.
And while we're talking about medication, we must remember that fluids, intravenous fluids in particular, really need to be thought of as a medication, as a drug.
Who prescribes them is probably something that it needs to be people who are working in paediatrics, I think, not people who are...
Often I will say the difference between an adult physician and a paediatrician. I'll talk about fluids, and an orthopaedic registrar will say, stick up a bag of fluids. A paediatric person should work out the calories, the sodium, the potassium content, have a very careful thought about it, work it out, mils per kilo per day, and then prescribe the fluid down to the last mil. So the devil is unfortunately in the detail. You need time and you need experience, because if you get that wrong, children can die from hyperkalemia or hyponatremia very quickly.
So one of the big areas in district hospitals is that pediatrics only looks after a fraction of the children who attend the hospital.
Sure.
They do not. The children go to a whole host of adult surgeons who look in over ENT, orthopedics, and so on. And the children in the surgical wards may not see a pediatrician ever. Has that happened to you as well?
Absolutely.
And that raises the risk. They never see someone who's child focused. So it's really, these standards need to be really addressed in saying what is in the best interest of the child. But the reality is that they're still going to have to do the surgery, but how do they get the support in order to do it?
In fact, I will say that's clearly a recognised problem in a district hospital. But even in a children's hospital, sometimes some of the paediatric surgeons have wonderful skills, but not necessarily in holistic approach to kids. So one of the rules we've instituted is that anyone who needs a surgical problem under 3 months automatically gets a paediatrician assigned to that case, because of the skills in combination as part of that team can be very helpful.
And also because on the training, the adult registrars rotate through the paediatric hospital.
Correct.
And may not have a paediatric approach. So there are these risks. I think that we need to move on to another area of what do you think the challenges are in the future for paediatric patient safety? Where we go in and where should we go? Because really we're about 3 or 4 years on the go. Pipsqueeze started 3 years ago in Toronto. We have a small group of people, about 6 people, and we now have got over 150 members, and we're hoping to have a big drive to get to 500 soon. And really the aim is to spread the word of paediatric patient safety so that we become a force within the quality and safety movement. But where do you think the challenges are for something like Pipsqueeze or for anyone who wants to be interested in paediatric patient safety?
It comes back to developmental milestones. I think we're no longer babbling, and we're finally sitting without support and maybe crawling. But it's time for us to start walking, and walking quickly. And I think we've always kind of, as I said earlier, been a little bit of a boutique attached to the adult quality and safety movement, and it's time for us to kind of become mainstream.
And I think that Johnny was talking earlier about measurement, and I think we're really not going to get to the next step until we can actually clearly measure the harm. And as soon as you can do that, you can start demonstrating it, and then we can also start coming up with some really practical solutions.
And it's about publishing so that people know about it. Because if you had to look at Johnny, you're on the Quality Journal,
Yes.
what percentage of the papers are from paediatricians?
A very small number. In fact, just last night I was talking to the editor of the BMJ Quality and Safety, saying, I think we should write an editorial saying, what a small fraction of the papers we receive are from paediatricians. Yet it's such a, let's say it's 25% of all the work out there, it may be 2% or 3% of the papers submitted. So we need to get our colleagues to publish, to recognise these issues and to publish mainstream.
So that's a challenge to you all out there. We want you to publish and
We'd
also
love to have
present.
articles. We'd love to have papers from
But,
paediatricians.
just on the side for the conference is that there are quite a lot of paediatric posters, but they're all splattered all over the place. And so if you really were interested in saying what happens to children, you have to really hunt, like a treasure hunt, to find out the posters. And there's 2 paediatric sessions at the conference, both on Friday afternoon, actually. So I think that what we need to do is really raise the profile.
Yes.
And really be more of a force. We're starting to get there, but maybe, as you say, to start walking very quickly.
A dedicated stream that runs through this conference and runs through, for example, the IHI forum, where people that are interested in the issues around children's health, around paediatrics, can have a dedicated track. We have so many other dedicated tracks. I think we've got to the point where we've earned that right to now in the future have a dedicated track in quality and safety.
I think one of the things we need to remember is that paediatricians are used to looking after children within the context of the family and the community, and that's what we do, and it's very inherent in paediatric practice. And so a lot of the challenges that the adult quality and safety movement are dealing with around connection of care and making sure that someone's got a voice, and you were talking about that before, we actually have already are a long way forward in that.
Yeah, but at the same time, I think we need to recognise that we, I think, as a professional body, do speak for children. But I think parents are the people who speak best, and often parents, by the nature of their job, they're so busy looking after children. It's just not a time in their life often they can give that advocacy, I think, to raise the profile of things like safety. And I think that's something we should look for and find a way to enable parents, I think, to do that.
It's very powerful. You know,
It is very
when
powerful.
a parent gets up and talks about a child of theirs that died from harm, that's a very powerful message that can really get the attention of people.
And I think major quality improvement in chronic adult conditions have come from patient advocates,
Yeah,
and people who've been able to speak for those conditions. So I think we need to encourage.
That's great. So we come to the end of the discussion. Any last thoughts you want to have on where we should go or what the challenges are out to the people out listening?
I just want to say the point that I made earlier. I'd from the BMJ Quality and Safety Editorial Board, would welcome papers around paediatrics and child health. We'd like to see them, review them, and hopefully publish them and raise the awareness and the academics around paediatric quality and safety. So that would be my personal message to the viewers viewing the session.
John?
Yeah, I mean, I think, like you said, paediatricians would hate to think that they would ever harm children, yet we do, and I think we need to realise that, and really that this should not be on the periphery at all. This should be part of our core business, is providing quality, safe care.
And Annie?
Well, and I think going on from that, when you were saying paediatricians do harm patients, and I think that it's not so much about what we all do as individuals. I think that we all need to also take the responsibility collectively for how we can actually reduce the impact of harm to children, in the broader sense. And as paediatricians, we need to take the lead on that.
I'm going to make one last plug. Everyone could just go to www.prpsqc.com, pipsqueak, and you could join up. Make this a movement that's really working. We need your support. We need more people to be involved, and that will drive the publications and the presentations. We need more papers coming to conferences like this, more paediatricians here, and we need to really remind our adult colleagues that all the chronic diseases of degeneration often start in childhood. So this has been a discussion of paediatric patient safety and quality at the International Forum here in Paris. I'm Peter Lachman, and thanks to Annie Molden, John Fitzsimons, and Johnny Tates. Thanks very much.
Au revoir.